This lecture will focus on the concept of gas exchange as related to the pediatric client. As you'll see in the coming slides, there are many differences in the respiratory anatomy between the pediatric patient and the adult patient, which is really important to be aware of. So we will begin. So this might sound trite, but if you don't have the A in airway, you are dead. As I worked in the emergency department for many years at PCH, when patients would come in, typically through EMS, via an ambulance, and if they were crying, we would all say, thank goodness they've got an airway and they're breathing. So crying is a good thing because you know they have an airway. Because without it, as I said, you're dead. And the A of ABCs is obviously critically important. This slide shows great pictures of the differences between the child's anatomy and the adult's anatomy. So the nasopharynx, or the area above the soft palate, is smaller. So why is this a problem? Because it can be easily occluded during an infection. The tonsils and adenoids are what kind of tissue? Well, they're lymph tissue. And what happens to them? They grow rapidly and they become swollen, resulting in an airway obstruction. The nose is smaller. Again, it can be easily occluded because of the smallness of the nose. The mouth is smaller and the tongue is larger. Well, the tongue can fall back and occlude the airway. If there is an issue with the hypotonia of the tongue, the epiglottis is long and floppy, so as a result it can become swollen with infection and occlude the airway. The larynx and glottis are higher in the neck, so there's an increased risk of infection. The thyroid, cricoid, and tracheal cartridges are what? They're immature, so they may easily collapse when the neck is flexed. There's fewer functional muscles in the airway, so it's harder to compensate for the edema and any spasm or trauma that might occur. The large amounts of soft tissue are loosely anchored, and mucous membranes line the airway, so there again is another risk for edema and obstruction with some type of trauma or infection. The eustachian tubes are short, open, and horizontal, and as a result, there's an increased potential for ear infections. The medical term for an ear infection is otitis media. Some of the contents on this slide bears repeating, but I think it's important to understand just how different that pediatric patient's respiratory anatomy is. So they have a short neck, and that means a short trachea, and this particularly becomes a problem in two ways. One, it's due to the shortness of the trachea, there's a greater chance for bacteria and viruses to enter the lungs because the trachea is short. Also, when a child is intubated with an endotracheal tube, the endotracheal tube can become displaced easily because of the shortness of the tube. So this is a huge issue. Infants are nose breathers. So what happens if their nose is stuffed up with secretions, NG tubes, suction catheters, etc.? They can't breathe. They have no airway. And remember that an infant cannot blow their nose. So as a result, they sneeze a lot as a way to clear their airway. Frequently, we'd have families come into the emergency department saying, "Oh, my baby's sneezing. What's wrong with them?" Well, they need to understand that this is a very normal reflex, and it's actually a very healthy reflex. The horizontal ribs prevent the bucket handle action seen in adult breathing and limits the increase in the tidal volume. By bucket handle, I mean that the ribs cannot lift up as like a bucket handle, and for us as an adult, the ribs can lift up, which helps to expand our chest cavity, but children can't do that. The ribs are horizontal. So as a result, to expand the lung volume, ventilation is primarily diaphragmatic. That is, they breathe from their diaphragm. Bulky abdominal organs can impinge on the contents of the chest and splint the diaphragm, reducing the ability of the diaphragm to adequately ventilate. The muscles aren't well developed to increase, and so there is an increased potential to tire easily. And what else? Well, the muscles there have a limited ability to store glycogen, so they fatigue quicker. The large amount of soft tissue in the airway is loosely anchored, which increases the potential for edema and obstruction, which we talked about earlier. With premature cilia, the waste products cannot be moved as easily, to discharge them from the lung area. And with fewer and smaller alveoli, there's less gas exchange going on. With increased compliance of the chest wall, due to the soft ribs, the rib cage cannot alter in size to help increase the volume, as I spoke earlier. Also, the chest wall is easily collapsed. Pulmonary compliance is a measure of the force required to distend the lungs. Think of their chest wall like a soap bubble, which can collapse easily. And what is atelectasis? It's a collapsed or airless lung. The higher respiratory rate increases the potential for fluid loss during respiration, which increases the potential for dehydration. And the oxygen consumption of a newborn is twice that of an adult. We can see that in their increased respiratory rate. So, therefore there's a higher oxygen requirement during times of stress and a more rapid development of hypoxia leading to bradycardia. Infants have a blunted ventilatory response, meaning that if they're hypoxic, they don't have the usual response. They won't be able to increase their oxygenation on their own as an older child or as we do. And lastly, the increased sleeping reduces their functional reserve capacity. So this functional reserve capacity is the amount of air left in the lungs at the end of a quiet breath. And this inhibits the intercostal or the other smooth muscles, and there is a loss of tone in the laryngeal muscles. This all leads to a loss of PEEP, or positive end pressure, which increases the potential for apnea. So as you can see, there's quite a lot of differences in the pediatric respiratory system. This is a picture of diaphragmatic breathing, which is very typical in the young child. We also call it belly breathing, and I urge you to look at that website that's noted, just so you can actually see a baby belly breathing. So what happens is, since the rib cage cannot expand due to the horizontal nature of the ribs that we just talked about, and thus those intercostal muscles aren't able to lift the ribs, they need to breathe from their belly. So children, especially infants, depend on their diaphragm to lower with inspiration to increase the lung capacity and volume, and to rise with expiration to help expel the air. The intercostal muscles only serve to stabilize the chest wall at this point. And again, that's why they're called belly breathers. Belly breathing is really an unusual way of breathing, and in an older child, I'd say more like a older school age to adolescents to adults, it would be called paradoxical breathing, because it's not normal in the adult world or in that older child world, but it's very normal for those young children. So again, please look at that website so you can see a baby actually breathing from their belly. So why is a prominent occiput, at the back of the child's head, why is that a problem? Well, if the child's lying on their back or they're supine, the prominent occiput will cause their neck to flex forward, and that might impair the airway. So what can you do to help this? Put a blanket or a towel or something underneath their shoulders, under their upper chest, to help decrease that flexion of the neck. Our tonsils are lymph tissue and essentially filters for virus and bacteria, as you can see in the picture of kissing tonsils. So we know that with infection in the lymph tissues, i.e. the tonsils, they become inflamed. Well, can you see how that's could possibly occlude the airway if they become too inflamed? The funnel-shaped airway in the pediatric patient is smaller and tapered compared to the adult airway, which tends to be more tube-like. So since it is funnel-shaped and smaller, there's an increased resistance to air. And look at how easy it would be for something to get stuck in that airway due to its funnel shape, like a Lego or a grape or a hot dog. And their large tongues take up a lot of space in the oral cavity. So if they're lying on their back, their tongue can rise to the roof of the mouth, occluding their airway. If you look at the picture of the baby lying on his side, what do you think is going on with his respiratory system? Well, remember, they don't have those rigid rib cages, so side lying causes their ribs to be squished, especially that underlying rib. Therefore, the upper lung receives better ventilation, while the squished lung has preferential perfusion and preferential ventilation. So in other words, that squished lung is not ventilating very well. Another issue that's really important to understand that it's for a toddler and older, it's important to let them be in their position of comfort as long as they're awake. They reflexively know what is the best position for them to breathe. But if they have a decreased level of consciousness, that reflex is likely absent. So if you walk into a room and you see a baby, like the one on the top, lying with his head flexed, and you notice that he's oxygenating okay, his color's okay, there isn't any changes in his vital signs, let him be. But if you walk into that room and the child's pale, the child's oxygen saturation's low, the heart rate's up, the respiratory rate's up, please, please, please put a pillow, a towel or a small blanket underneath those shoulders to help decrease the flexion in his neck. So again, this less alveolar surface area for gas exchange in infants and young children causes a problem. Those narrow branching peripheral airways become easily obstructed. They don't have many collateral pathways, so they're unable to compensate for obstructed areas. So all of this results in atelectasis or collapsed lung and an obstruction, especially as a result of repeated infections. So again, you're thinking of your ABCs. If you don't have an airway, you're not going to be breathing and you're going to be dead.